Good morning and welcome. My name is Dawn Gresham, and I handle health policy for Senator Krueger. Senator Krueger is unfortunately not able to be here this morning, but she sends her regards to all of you. I would like to welcome program attendees who are viewing this event on Zoom and Facebook, or who are calling in to the second session of the 2024 Older Adult Roundtable series. This morning's program is titled Making the Transition Safely, Planning to Leave the Hospital and Go Home. As always, we have closed captioning for today's event. As a viewer, you have to activate closed captioning to view the text on your device. If you are watching on Zoom, click on Live Transcript in the meeting controls to start viewing closed captioning. If you are watching on Facebook, you will see a settings button in the bottom right-hand corner of the video. Click on CC for closed caption to activate the process. This forum is being recorded, and everyone who RSVP'd will receive an email with a link to the event video, as well as the resources that are posted in the chat and the presenters' PowerPoints within a few days. And now we will move on to our event. This morning's roundtable will focus on healthcare and aging in place, two of the pillars outlined in New York's Master Plan on Aging. One of the main reasons older adults require nursing home placement is unsafe hospital discharges, which do not consider appropriate supports at home. Today, our presenters will provide information about home care and what you can do to help ensure a safe transition from the hospital to your home. You will hear from experienced professionals what home care agencies can offer, about different mechanisms to pay for home care, and how to interview a home health aide. We have lots to talk about, so let's get started with introductions. Our first two speakers are Laura Radensky, the Executive Director of Concerned Home Care for the Elderly, and Sharon Goodstine, Adjunct with Brooklyn College, both of whom will talk about home care options when you are discharged from a hospital stay, how to pay for care, and the challenges you may face in the current workforce environment. You will also hear from Jamie Meconi, a social worker at COHME, who will give you guidance on how to interview a potential home care aide, share information about some of the hidden costs you may be charged, and your rights as a consumer. After the presentations, I will moderate the Q&A portion of today's event. Now it is my pleasure to introduce Laura Radensky, Sharon Goodstine, and Jamie Meconi, who are presenting together. Please turn on your cameras and unmute yourselves, and I will hand it over to you.
Okay, all right. And let me, okay. All right, good morning. Again, I'm Laura Radensky, the Executive Director for Concerned Home Managers for Elderly. So I thank you, first of all, for having us present, but I also want to give kudos to everybody who is attending, because all of us at some point or another are probably going to find ourselves or our loved ones in that hospital room or that nursing home rehab room with a very stressed discharge planner coming in quickly saying, okay, you need to discharge, you're going to need home care. I'm going to take care of a small part of that. And, perhaps they'll give you a list and say, here, choose and figure this out, and they go on to the next patient. So it's really important that you have as many tools and information as you can when you're planning. So we're going to start today, as Dawn said, with talking a little bit more about which insurances that you currently have might be able to assist when you might need to consider applying for Medicaid, how to afford the other types of care, including if you do have long-term care insurances, how those work. And then Jamie is gonna finish up with the third part, talking a bit about how to find the best agency and to do interviews in order to choose a caregiver. I'm going to turn over now to Sharon Goodstine. Sharon also was previously Director of Social Work for the home care at Health and Hospital Corporation and has had many years of experience with Medicare and Medicaid home care. Okay, Sharon.
Good morning. I definitely want to talk about the importance of insurances and how insurances compare and in terms of what you're eligible for, how you're going to get care, how much care you can get, and what that care is going to provide and not provide. We're starting with Medicare because it is one of the, of course, most common coverages for seniors and disabled individuals. And it covers what we call CHA services, Certified Home Health Aid Agencies. And these focus on skilled services. What are skilled services? That's nursing, physical therapy, occupational therapy, and social work. But what you do not see here is home health aid. You see other services, skilled, but home health aid is not considered a skilled service under Medicare. It's an adjunct therapy to assist in your recovery from your medical issue for which you fear would probably hospitalized. And at that point, you're not covered for that unless it's something that involves personal care. The government has created several other types of services under Medicare, which include things that we may have heard of. You may have heard of Medicare Advantage plans, Part C, if you see the advertisements on TV. There are some that actually do include Medicare and Medicaid together, and there are some that are solely one or the other. When you're going to leave the hospital, which of these coverages you have is crucial in terms of determining what you're going to be able to get, how quickly you'll be able to get it. And when you're leaving a facility, let's say a hospital facility, and you're not really ready to go home and you only have Medicare, one of the things we rely on is going to be discharge from the hospital, possibly to an alternate level, such as a rehab, prior to going home. I urge people to think about that before they come home, because when you're going through and you're looking at what you're going to get under Medicare, okay, home health aid services are going to cover your personal care, your condition for which you're on the program. It's not going to include housekeeping, not to be taking you to medical appointments. It's not for shopping. It's for personal care, which supplements your care from the professionals. So the physical therapist will teach you and the aide will assist you in using a shower bench. You may need assistance in using a commode. You may need assistance with things in terms of bathing and grooming. Those are all hands-on care provided by an aide. The aide services also are solely for you. You may live with an elderly spouse. You may have someone else in the home who you were taking care of. That aide will not and cannot assist that person. And that's something we need to think about, because sometimes people would be okay, but the person in the home that they were living with is not going to be okay once they can't help them. So at this point, we can move on to the next slide. Okay, so accessing CHA services. Okay. When you're in the hospital, you're often seen by a social worker, but you're also likely to be seen by someone from discharge planning. A lot of discharge planning services have been taken over by nursing, and it's supposed to, in fact, allow for an assessment of what your condition is going to be at discharge and what kinds of services you are going to need. And should you consider a rehab rather than going home? And that's something that people are going to have to try to find sometimes, unfortunately, in the hospital, because these departments are sometimes overburdened. And also, sometimes a decision is made very precipitously, for example, by the treatment team or the doctor, and they say, oh, you have to leave tomorrow. But the time to think about what's going to happen when this person goes home is the same day that they're admitted. That's when you start. You don't start when someone says, yeah, the person will be going home in a couple of days. You start from the very get-go. And to do that, you have to talk with the doctor, you have to talk with the people of the team to determine if they're going to order home care. Home care under a certified agency has to be ordered and signed off on by a physician. It can sometimes be done from the community, but mostly from the hospital. So at this time, there have been some losses in child services and availability. Some of that obviously started with COVID and with the pandemic. We lost a lot of home health aides, and the ability for agencies to continue has been very difficult. So first of all, they have to find an agency that's willing and able to take your case. It has to be signed off on for a certain number of days. A maximum under Medicare is 60 days. Some home cares are trying to review cases at 30 days to determine if you still meet the Medicare guidelines. And any non-skilled services like the home health aide that we discussed, unfortunately, will have short hours and may not even continue for the whole time that the skilled services continue. It depends on what the aide is actually needed to do and how you're really demonstrating that need. Next slide. Okay. Now, what happens when Medicare isn't going to cover the services or all the services you need? Or you're going to be not, unfortunately, going to continue to need skilled services, you're going to need other kinds of care in the community. So what you have to do here is you have to look at other kinds of things, first of all, that you may already have. For example, do you have a long-term care insurance policy? Many people bought these years ago. Sometimes they put them in drawers and they forget about them, or they haven't read them in a long, long time. You don't understand. How do you activate them? It can be difficult because you have to go through this. Sometimes you'll need assistance from a family member, from a social worker, from a community agency to determine what's needed. And if you can get that, you have to understand it's limited usually by who the person is. Sometimes it used to be able to be a family member. More likely today, it's got to be a certified aide, and for how long and how much care you will get. Then, of course, there's Medicaid. Medicaid is the provider of choice for any long-term care needs. Besides having, of course, the money to private hire somebody that you choose for as many hours as you would like, who can basically do pretty much what you direct them to do. In Medicaid, there are lots of opportunities for long-term care through what we refer to as managed long-term care programs. And they are basically there to assist both with skilled, like some type of personal care. They're also there to do housekeeping, shopping, accompaniment to appointments. They provide additional services that are not covered under Medicare. Then there are licensed agencies, as we talked about, you can use for private pay. There are community services. Well, what are those? That's through the New York City Department for the Aging. There's a program called ISEP, E-I-S-E-P, that provides subsidized home care for people basically above the Medicare level, but not able to afford it, and below the Medicaid, where they feel they can't qualify for Medicaid as they have too much money. So they're in betweens. You're too rich for Medicaid, but you're not really rich enough to private hire. Provides short-term personal care. Have to need personal care for that. Some New York City Department for the Aging agencies do other things. They do transportation. They do maybe some housekeeping for you. They can provide things like that. And then there's illness-related societies, which are very, very important. Illness-related societies can also help you. They help you with planning. For somebody who has MS or who has Alzheimer's. They help you with support services. They help you with counseling, and they support sometimes different types of benefits. Maybe they will give some funds for somebody who needs taxi services to a doctor. Maybe they'll provide funds for somebody who needs very short-term accompaniment to things by an aide. They can provide other kinds of things like that, in addition to things like for cancer survivors and people, wigs and prosthesis and things that are not covered under their coverage. So these are all the different things that, and agencies and things we need to look at for people who do not really get what they need from Medicare. Next slide. Okay. Looking at Medicaid, unfortunately, we're always looking at money. We are looking at your income for an individual. Here's the standard for an individual and for a couple. We're also looking at asset levels. Now, there has been a big increase in that. Over the last few years, they have really upped the amount of money you are able to have. It used to be something like $1,500. So now we're at $31,000 for an individual, $42,000 for a couple. Now, the important thing to understand is that there are different ways to qualify for Medicaid. This is just a standard Medicaid income and resource level. It does not deal with many of the other things, which we're going to talk about as to how we can sometimes get services under Medicaid. The first thing we want to look at are, what are we going to do for people who are married? Okay, one of the things that people who are married can do is they can, if they want to apply for a managed long-term care program, you are going to be applying for one person, the ill individual. So again, will be no services for the what we refer to as the well spouse. This is based on changes that were made in nursing homes, where back in 1986, actually, the federal government said we should not be impoverishing people who have the unfortunate situation that their spouse has to go to a nursing home. So they decided that what they would do is they would allow the person we refer to now as the community spouse to hold additional assets and resources, additional information. And so only the income of the individual would be looked at, and the resources can be transferred to the well spouse. This works for managed long-term care programs. Does not work for any other type of Medicaid, but you have to, if you enter an MLTC, it's possible to get the MLTC to assist you with a spousal enrichment application, in which your spouse will get the care, you will hold the resources. Sometimes, however, that does not work, either because you're still well above what you're allowed to hold on to, or there are other problems that you have. So in that case, spousal refusal is an option. I talk about it because it exists in the regulations. There are absolutely forms for it. However, Medicaid will rarely tell anyone about it. Why? Because they don't like it. Honestly, they don't like it. Because it allows you to say, I'm not going to support my spouse for medical bills. Some people don't like it. They would never do it. They would say, I would never sign a paper. You also have to understand you're signing a paper that also says you could be sued. Will you be sued? Well, questionable. Certainly for lots of assets and for people who do this in a nursing home, sometimes they are sued. Can you be sued in the community? It's a possibility. That's why it's something that you need to consider, and consider whether you should get legal assistance or legal advice, because there is something that you have to do. A more positive thing that we can do is the pooled income trust. Pooled income trusts have been a significant help to people who could otherwise qualify for Medicaid. They're under the allowable for their resources, or maybe they've actually transferred their resources, which you're actually also still allowed to do for home care, not for nursing home, but for home care. Okay. However, they have income. They worked. They have an income, or they had Social Security of $2,000, $2,500, $3,000, which in today's world, that's not a lot of monthly income, but it's still above what, even with the changes, it's still above what Medicaid allows. What can you do? How would you pay your rent? How would you pay your bills? You need the Medicaid because you need the hours. What are you going to do? You can go to a nonprofit agency and set up something that's called a pooled trust. Why is it pooled? It's not your individual trust. You didn't go to a lawyer and do a trust. You went to this. It's like a bank account, except it's a trust account. And then you pay your surplus as determined by Medicaid using Medicaid guidelines. And let's say your surplus is $600 a month. You're going to pay that to the pooled trust. You're also going to pay them a small fee or some type of a fee. It's usually not a huge amount, but there is definitely a fee because they do this for you. And the rest of that money, you're going to be able to use to pay your bills. The original way the pooled trust was set up is that you sent your bills to the trust or arranged for the trust to pay them. Recently, some pooled trusts have developed a thing where they actually give you a debit card and you can then continue to pay your own bills. That depends on the pooled trust, and that's something you have to research. Lawyers help you with this. Community agencies can help you with this. And managed long-term care programs can help you with this for sure. Okay, so many managed long-term care plans will assist you in getting Medicaid, okay, because you have to have it in order to join their program. And this is basically a form of insurance in which the company is paid for every day you're on their program. Basically, that's how they are paid. They're not paid by you. They're paid by a set amount of money and everything. And then they provide the home care services to you. Okay, so this is something where they give you a range of services. They give you an aide. They can give you a care manager. They can assist you if your condition, unfortunately, were to deteriorate, to help you possibly apply for more hours. Many of them have their own social daycares. They provide you with transportation to your appointments. So they cover a lot of things that you will need in order to be safe and in the community, especially if your condition continues to deteriorate and unfortunately you're not able to resume your prior level of function. Okay. Now, how to get it? You can always contact managed long-term care programs directly. They're listed in the New York State Department of Health. They are available online. You can read about them, you can have interviews with them, and you can have them come out. However, they are no longer allowed to determine the hours that you will get on their program. When the MLTCs were first developed, they told everybody how many hours they would get. Now, New York Medicaid Choice, an independent assessor from the state, is going to send a nurse, or I think they were doing Zooms because of COVID. Some have resumed in home, but you have to be assessed by an independent assessor. If you need extended hours, higher hours, more than 12 a day, you have another level of assessment, which is done by a physician. All of this has unfortunately decreased the numbers of hours that people are receiving on managed long-term care programs. Receiving 24-hour care or split care, shift care, so you're having two 12-hour people, has become very, very, very difficult. Most people get about 5 hours. Now, many of you have also heard about consumer-directed programs, CDPAP, where you can hire even a family member. You can hire a friend, or you can hire somebody to be your aide. Okay. The CDPAP program obviously allows you the max and flexibility and freedom. You can choose your caregiver for the hours that are approved, and only for those hours, of course. And they also allow people to be what we call family employed substitutes. So those are people who can also be trained to do certain skilled care. Let's say you have a colostomy or you need an injection. A certified agency can train this person. And once they're fully trained, they can actually do this care, which an aide normally could not do. So it makes it very flexible for people. However, the thing you also have to remember, though, is you're responsible for hiring and training and supervising whoever this person is. So you always have to have backups. If your plan is to hire a family member, you can't just have one family member. Be responsible, because if that person themselves becomes impaired or needs a vacation or has to go away or some crisis, you will have nobody and it is not the state's responsibility or any agency's responsibility to send you anybody, because you have chosen consumer directed. So people have to be careful about what they do. Hospice is a program that is basically, and has always been basically, a Medicare program. Some people look to hospice because it does continue your services under your Medicare. And there is also palliative care, which is a slightly lower level of responsibility in terms of how much care and how long you're going to get it. Hospice is pretty much limited to people with a prognosis of 6 months or less. But the other thing that it's also limited to are people who clearly understand themselves, that they have a condition for which they will not, unfortunately, live. And one of the things that you agree with your hospice benefit under Medicare is that you will not seek medical attention in a hospital for that care. You can get supportive care at home. You can get treatment at home for other kinds of things. But for the thing that you chose, so if you are supposedly, unfortunately, having some type of a form of cancer, and you have an emergency related to that disease process, you would have to leave hospice if you want to go back on Medicare, which you can do. You can do it, but you can't have both. You can't just say like, well, I'll go on hospice, but if I get sicker, I'll go back to the hospital so I can get more treatment. This is supposed to be when we decide that we're ready to understand that there isn't going to be more treatment. Does that mean people don't outlive hospice? They certainly do. And that's because hospice has enlarged its coverage to things like Alzheimer's. Accessing it, again, you're going to agree not to go to the hospital. Sometimes, as I say, people become very focused on the 6-month business. It is not really possible sometimes to determine if someone's going to live 1 month or 6 months, even by the best specialists in the best hospitals. And people can always hope that they will do better. This is a program for people where you can at least get ongoing support. What do you get from hospice? You get a doctor, availability of a doctor 24/7, who can also come to the home. You can get nursing. People will come to the home. You can get spiritual support if you prefer to use theirs rather than maybe your own. Maybe they will send a chaplain, somebody that you can speak to on a regular basis, a social worker, someone you can speak with and the family can speak to. So that it's very warm and supportive. Hospices also have their own inpatient units. And sometimes if care at home really does become impossible, you actually can enter an inpatient facility. It can be a specialized standalone hospice, or it can be hospice beds within a nursing home type facility. And these are things that are very, very, very important because this kind of support is really needed. Okay, and that covers my area.
Okay, very good. Thank you, Sharon, so much. And again, I'm Laura Radensky. I am going to focus in this part a little bit more on kind of like a larger overview of the licensed home care agencies. And one reason that home care is so complicated and a little bit difficult to understand is because there are these different layers of the care. So because the licensed home care agencies are actually those agencies that directly employ the home health aides. So they are, so both the Medicare and Medicaid providers will subcontract with licensed agencies, but in addition, you can directly contract with the licensed home care agencies and privately pay for care. In addition, the licensed agencies, or they're sometimes called by their acronym LCSWs, do employ nurses and licensed practical nurses. The nurses are going to supervise the aides, but there also is the possibility for complicated medical conditions of having private duty nursing or private duty LPNs through those agencies as well. Some of the benefits are they are overseen by the New York State Department of Health. as I said, then there are nurses putting together a plan of care and overseeing the aides. So they are able to provide hands-on care, grooming, bathing, and those other things that, like Sharon was mentioning, that are provided through Medicare, licensed agencies can provide. Sometimes you have to use an agency if you have a long-term care insurance plan that specifies that. Many of them do. But again, I'm going to emphasize very much that you need to check your policy, because sometimes they do allow for hiring otherwise. But in many instances, it has to be an agency. And another benefit of the agency to really keep in mind is that they are going to have that backup staff. Right. So they are going to, you're getting that 8 a.m. phone call of so-and-so's child is sick, they're not coming in. An agency is going to be able to say, no problem, I can send these other people to you. And they're going to have that 24/7 on-call staff coverage. They have to have nurses available at all times. It is not easy to choose them. There are more than 400 different agencies in the downstate area. Usually you can certainly do the research by looking them up on their websites, checking out reviews, etc. But to access them, you usually should, it's recommended you call and speak with them, although you can start the conversation with an email. Other ways to find out about agencies. So as I mentioned, again, when you're in that nursing home or facility room, or hospital, you are going to usually get some lists. But as Sharon mentioned, it's good to keep in mind that especially if you're dealing with a specific illness. So for example, like the Parkinson's Foundation has done special training with our aides, so that they know how to kind of deal with like when the medication is given or mobility issues. So sometimes it's good to go to those agencies like for Dementia, Caring Kind, Alzheimer's Association, and get lists from them. But word of mouth is another way you'll find out about agencies, or social workers or care managers. And so the question that often comes up, well, if you have long-term care insurance, what's it going to cover? All of those policies are individualized. So it's really important for you to check the policy and go over it. There are people even that you could hire to help you to if you need advocacy for it, but you as a policyholder must put in a claim directly and obtain approval. The approval is often based on how many activities of daily living the person needs help with. Usually it's a minimum of at least 2 or 3. And many of those policies do have an exclusionary period of like 60 days, 90 days. But again, it is individual to the policy. The other thing I'll say is some of them have strange ways of counting those days. So I've heard of policies that say, oh, 1 day is going to equal a week. Or 1 hour is going to, even if you're just getting 1 or 2 hours for the day, that's going to count as a whole day. So important to check that out. As Sharon mentioned, the other resources are through the case management programs, the ISEP program. I will caution though, there are often very long waiting lists and limited numbers of hours. And they really have a preference for providing those services to those with more limited incomes. So the question that always arises is why is the care so expensive? And just as an example, so we're $37 an hour. But that's not very far off from the market rate in general for agencies. And that really is for a number of reasons, one of which is that the minimum wage for home care workers in New York State is different from the general minimum wage. General minimum wage is, I think, $16 an hour right now. For home care workers in the state, it's $18.55, and it will go up again in the next couple of years. And that is for any home care worker, not just those who are working under, insurance, under Medicare or Medicaid, but everyone. Other things impacting the cost of care, payroll taxes, agencies have to have liability insurance, which is really important, workers' comp, some of the, nursing salaries. But another thing that's been impacting those costs is really the labor shortages. This is an aging workforce. We saw a lot of aides and nurses leave the workforce, especially during COVID, and it's very challenging work as well. So I'm just going to talk now a little bit about some other aspects of licensed agencies. So all aides will have certification. They need to have 2.5 to 3 weeks of full day trainings by a nurse in order to get that certificate. And in order to keep the certificate ongoing, they're mandated to do 12 hours per year of training. And training is crucial, especially when they're dealing with such challenging situations as, right, that person who's going to ask, when is their daughter coming home 10 different times? You want to have someone who understands what are the processes that are going on so that they can have patience, or what do they need to do if they're dealing with end-of-life illnesses. When an aide is certified, they are not able to administer medication, but can provide medication reminders. The state attempted a few years ago to pass an advanced home health aid bill in order to allow some aides to have more training, but it hasn't really been implemented. So the aide can actually take medication out of a bottle or out of a mediset, you know, the box that medications are in, put it in someone's hand, but that person still needs to put the medication in their own mouth. So crushing pills into food and feeding it is a no-go. Injections are a no-go. And it's just important things for you to be aware of. So when you get that discharge planner coming in saying, hey, actually you need 24-hour care, you have a couple of different options. You could have 2 different aides for 12-hour shifts each, right? One daytime and one nighttime. But there's also something called live-in services, where you would have one aide working all 24 hours. That means that they would be, for example, from 8 a.m. Monday until 8 a.m. Tuesday, one person. So that means that they're going to need, under Department of Labor rules for New York State, to be able to get 3 work-free hours of mealtime as well as 8 hours sleep, 5 hours of which must be continuous. The agency is going to be responsible to pay the aide for all 8 hours if they're coming back saying, oh, I really wasn't getting sleep. So what does that actually look like? So if somebody is maybe getting up a couple times in the night to go to the bathroom, that usually is fine. But if they're waking at 2 a.m., 4 a.m., 6 a.m., because they're not aware of, you know, whether it's night or day, that means they really should not be having live-in service, and it's just important for you to be aware. There's been a number of court cases challenging the live-in services. Department of Labor's continue to support it, mainly because the Medicaid system would really be at risk. But the impact of some of those court cases is that there are less agencies providing it, and so therefore less availability of live-in service. So if you are having live-in service, just ensure, you know, make sure with the agency that you know what the payment might be if for some reason one night the person isn't sleeping, and also ask them about backup. You know, make sure, even though they've come up with this one person who can do the live-in, are they going to be able to do that otherwise? So I'm going to hand over right now to Jamie Meconi, our social worker. Thank you.
Hi, everyone. So I'm going to take some time, refocus us back to transitioning home from the hospital, and specifically discuss when you may need to consider hiring private care and what that process will look like. So to reiterate some of what Sharon shared earlier, you know, the hospital is going to make recommendations to you regarding your discharge, what level or type of care that is needed when you leave. You know, some of these evaluations may start as soon as you get to the hospital. You know, an assessment from the physical therapist, maybe recommendations from the medical team. Also an assessment by either a social worker or a nurse care manager, which, by the way, you know, can definitely be valuable assets to you when discussing your options for your discharge, providing resources, list of agencies, etc. So care recommendations could include a short stay in a rehab center or in-home help, nursing visits, maybe if you have a wound and need wound care, physical therapy to help you recover from an injury or surgery, The care team may even make specific recommendations, like you need a home health aide for X number of hours per day. So if the planner recommendation is to return home with home care, so maybe, rehab is not an option either because of insurance or you don't qualify for rehab level of care, or maybe you don't want to go to rehab. And given everything that we just heard from Laura and Sharon about the limitations of in-home care covered by insurance, you may be in a position that you really need to privately hire. And maybe you need to do this just until you can figure out a long-term plan, maybe applying for Medicaid, pooled trust, etc. But you need the support, ready for you on the day of your discharge. So two main options when you're thinking of privately hiring. You have the option of hiring a private aide or through a registry. So this may be through a personal referral, maybe a friend, family member used an aide previously, recommended them to, maybe someone in your building had an aide that they used to work with. Or if you're working with a care managers have, private registry of aides. So if you're hiring in this way, you're going, or your family will be the employer and you'll be responsible for handling the entire span of details associated with that. And the other option, as Laura just spoke a lot about, hiring through a licensed certified agency. So regulated by Department of Health, retain a staff of trained and certified caregivers supervised by a nurse. And the agency is going to then coordinate all the necessary responsibilities with hiring personnel, background checks, employment verification, payroll, taxes, etc. How much care do you need? What are the options when arranging care? Schedule options? What things do you need to consider when determining what type of private care is right for you? So hourly versus live-in care, and what does that mean? So hourly, you're going to set a shift start time and end time based on your needs or wants, and it's charged by an hourly rate, keeping in mind that most agencies and or aides will have minimum shift requirements, possibly length of care requirements. So typical shift minimum is going to be around 5 to 6 hours. And, this is consecutive. So in other words, it can't be broken up like an aide coming in the morning for 2 hours and then in the evening again for 3. It's going to have to be a, continuous shift. Also, there may be a weekly minimum with COHME. It's 12 hours per week, but that may be more or less depending on the agency or aide. Also, keep in mind that the scheduling can be flexible. As you recover from your hospital stay, you may start out with service, having an aide or request an aide to 7 days a week, but then maybe, week 2 or 3, you only need an aide a couple of days. And, and agencies understand that. It can work with you, based on what your needs are. And then live-in care. So, obviously Laura just touched on this, this is an arrangement of an aide sleeping over for a consecutive number of days. Typically in this arrangement, you may have an aide working, 2 aides splitting the week, 1 aide working, say, Monday morning, leaving Friday morning, and then the second aide coming on, for the Friday and weekend shift. This is normally charged by a daily rate and can be a more economical option for someone that does not want to be left alone, but does not require the attention of an aide, all throughout the night. But also, as Laura mentioned, there are, strict Department of Labor rules regarding this to ensure an aide is sleeping at night. So, it's not appropriate for all clients. Aides must sleep 8 hours total, 5 hours uninterrupted. And if these requirements are not met, an aide is required to report this. So, this could then result in additional charge of 8 hours of care on your bill. And something else important to keep in mind is that, your apartment has to be appropriate for the accommodations of a live-in service, a bed for an aide to sleep in, a private area for them to sleep. So what does all this cost? So Laura also mentioned this, typical range, I would say 35 to 45 an hour. COHME, for example, is 37. Live-in, probably 450 to maybe 550 per day. And there may be differences in rates depending on how many hours a week you request. In other words, more or less depending on the schedule. Private aides not through an agency that you are hiring on your own, maybe a little bit cheaper, maybe 25 to 30 an hour, but Also, you may then not get the same supports that an agency is going to provide. And then lastly, I just want to mention, if you have a spouse or partner at home or someone else in the home that needs some help, you'll need to discuss mutual care. So this would then allow your aide to help, both of the people in the home. There will likely be an additional charge for this. The exact amount will depend on the aide or agency. And I'm bringing this up because it's important to know that, you can't just assume that your aide will help both of you, even if it's just for small tasks. There will likely need to be a more formal arrangement in place that would include additional costs. Okay, so things to consider, when choosing what type of private care or agency suits you best. Who's going to supervise your aide? If you're hiring privately, it's going to be you. If it's through an agency, it's going to be the nurse, employed by the agency. What if urgent issues arise? What's the policy or procedure if your aide calls out sick or takes vacation? Is there backup available? If using an agency, what other services or supports does the agency offer? Is the aide that you're considering hiring certified? Are they required? Any ongoing education? As Laura mentioned, Department of Health mandates that aides working with certified agencies complete a minimum of 12 hours a year of ongoing education. Any specialized training or experience? Definitely this could be important if you or your loved one has a specific diagnosis or care needs. Are there any tasks that that you need your aide to do, but that they can't do? For example, pre-pouring or administering meds. Private aides may be able to do this, but aides through an agency cannot. And also, can you use your long-term care policy with your aide or agency? And is there anyone to help you apply to your policy if you need assistance with that? An agency may have support staff or a social worker to help you with that. So what to expect during the intake process. So this is speaking more to, if you're working with an agency, and, every agency is different, but some general things to expect. The agency is going to, do their own staffing assessment, making sure that they have staff available in your area that matches the schedule you need. Some things that may impact the availability of aides, like if you're requesting a shorter shift, there may be less aides that are comfortable working those hours. Or if you have pets in the home, definitely there's aides allergic to animals, might limit the available staff. So there'll likely be some sort of intake visit with social worker or agency staff member. Process with COHME includes a visit from me, and I can do that in the hospital. Definitely helpful in making sure we are matching our clients with aides we feel are good fit, have the experience to handle client-specific needs. Some agencies will not require this visit, others, could charge for it, so it just depends. A service agreement will need to be signed by you as the client or a designated power of attorney. A security deposit also could be part, deposit that the agency will hold on to while you're on service. Some agencies don't require that. The intake process will also give you an opportunity to also, discuss the points from the last slide, making sure you're asking questions about emergency protocols or what other supports are going to be available to you through the agency. Also, an opportunity to discuss, maybe you want to interview a potential aide, or asking the agency's process if, an aide starts and you don't feel like the right fit. You don't feel like the aide is the right fit. Who do you speak to if you have concerns about your aide, or if you're uncomfortable about something that's going on? So if you decide or have time and want to interview a potential aide, some questions to consider. Of course, make sure that your aide knows and is comfortable with your schedule needs and preferences. Some other questions maybe to consider: why did you become a home health aide? What sparked your interest in the field? Why do you like working with older adults? What are your hobbies and interests? Definitely can be helpful in maybe getting to know their personality a little bit. Do you have any special training or qualifications, or, experience with dementia, if that's, applicable? Do remember that it is a job interview, so, take care with personal questions, being careful maybe to ask things like, do you have children at home, or something that is more, personal. But So lastly, I just want to mention, being in the hospital, getting discharged from the hospital can be very overwhelming and stressful. So care management could be an option that you might want to consider. Are you having a hard time managing your medical care? Do you lack supports in the area, family, friends, or other people who can help you manage things? Geriatric care managers are professionals who perform a variety of tasks for older adults, can make home visits, accompany people to medical appointments, oversee home care and planning for the future. Some home care agencies may offer some care management support included, or possibly like as an add-on service. Or there's independent care managers out there, companies that provide these services. Also, some long-term care policies may include a small care management benefit, so something to look into if you have long-term care insurance. But care managers can definitely be a very, very useful and important source of support. So I'm going to pass things back to Laura for some closing comments.
Okay, and let me just start video again. Okay. Yeah, so so one other piece I want to mention is that in instances with an agency, in instances where they don't have social work as a main part of the services that they provide, that they always, and they are mandated under Department of Health to have a nursing visit. And actually another piece you should know is that whenever an aide is changed to a new permanent aide, somebody who is going to be ongoing, there is supposed to be an in-person nursing visit in order to provide orientation to the aide regarding the case as well as regarding the plan of care. So just in summation, as I kind of shared a little bit, it is a bit of a complicated structure, and we hear all the time people saying, okay, I thought I was with so-and-so Medicare provider agency, but now they're mentioning the name of this other agency saying they're the ones that are at fault because the aide didn't show up. All right, so again, we wanted to really make sure that you understood about the fact that there is this subcontracting that goes on by all the Medicare and Medicaid providers. It doesn't mean that you still can't advocate and certainly make both agencies aware if you're if you want changes. But just an important piece to know, it is care that long-term care in general is expensive, and there's a lot of different impacts, but it's good to know all of your options for cares and ways that you can make sure that you're hiring either the best agency or the best staff. And I hope this was helpful in terms of talking about the interviewing, service agreements, etc. And this is our mine and Jamie's information, as well as our email address and our phone numbers. Again, there will be PDFs of the slides going out, and so you will be able to receive that there. But I think we are now going to be, Dawn is going to be coming back on in order for us to be able to go into the question and answer session. Thank you so much.
Thank you, Laura, Sharon, and Jamie for providing all of this helpful information. Now I will moderate the Q&A portion of the event. Just to remind you, we will send a follow-up email with links to the event video with all of the resources listed in the chat, as well as the presenters' PowerPoint presentations. We will start with the questions that were sent ahead of time, but remember, you can post questions in the chat as we go. And let's get started with the first. So we have a number of questions that reflect concerns about decisions made in the hospital. So regarding being discharged from the hospital, how can a person, either appeal or prevent a premature discharge? Perhaps they don't feel well enough to go home, or perhaps they don't have the setup they need at home. What can someone do?
Well, I think there are several problems with the way that we're looking at the situation. First of all, we need to understand that, as I said earlier, when you arrive at the hospital, that is the time to start to think about how I'm going to leave the hospital. How will I be safe? And this is very important for people who've been, what shall we say, managing somewhat, but not really very well, and haven't been able to really accept the fact that they need a plan. So the first thing that we need to do is we have to hope that this person, with whatever support people they have, take an honest look at what services are going to be needed at home and what are they going to do if, for example, even if they have Medicaid, you still have to apply. Nothing happens immediately. So you also have to work with the hospital. What is an alternative option? Can they get them into a step-down unit? Is there a way to get them healthier? Can they actually, some hospitals have their own inpatient rehabs. Can they move them there so that they can use their Medicare benefit to get more care? Then can they meet with someone in the hospital to talk about long-term planning? But the first thing that they have to do is to realize that the hospital has a responsibility to make safe discharges. There is no question about that. But people have to be realistic that social admissions to hospitals are no longer something that hospitals do, to be honest. So we need everyone involved with this person, themselves, their family, and the hospital staff to talk immediately as soon as there seems like there's going to be an issue to see what can be done.
Thank you. And what if a patient was told that they would be discharged to a rehab facility, but then they're told that they're going to be discharged home? Can you appeal this kind of decision?
Yes, you can always appeal a decision about a discharge from a hospital. You can actually appeal under Medicare a discharge from a certified agency. You have a right to appeal. However, that doesn't mean you'll be sustained. And it doesn't mean that you will be covered for all the time you're there if you're not sustained in your appeal. So the first thing to do is immediately, it seems to me, talk to the care team. Explain what the issues are. What is it that you can't do? The sad part of this is if it's not a medical thing, if it's a medical thing that you're going to need, you're going to need wound care. You're going to need IV infusion. You're going to need something, and you just can't do that. You don't know how to do it. You can't do it. You have nobody there to do it. Then really, obviously, some arrangement has to be made. If it's because you won't be able to go shopping, or you won't be able to cook, or you won't be able to clean, you have to, hopefully, you have someone to help you. But if you don't, you have to look realistically at what you're going to do. And that means sometimes, unfortunately, for people who have money that they can use to hire somebody, even temporarily, to come up with something. Go to a community, if they're involved with a community agency, ask them to assist them. Something that you can do at least temporarily. But the most important thing is open communication and, to be honest, a realistic attitude. You have to admit when, as you get there, that you've been having a problem. Because most people who haven't been having a problem and get there, get better and go home. It's the people who unfortunately have been just getting by.
Yeah, and the one other thing I want to say about that is I often hear from people, well, I put in an appeal, so everything's going to be fine. I can stay. And I'm like, no, do not be so optimistic. Oftentimes, even if they do approve an appeal, it's for a 24-hour period, just to give you a little bit more time to get the discharge plan in place.
And that's helpful to be aware of. Thank you. One last question, thinking about, while folks are still in the hospital. So you've provided very helpful tips for thinking about arranging for, home assistance. What about things like wrap bars? If someone doesn't already have safety mechanisms like that in place, do you have any recommendations for what can be done while a person's still in the hospital?
Yeah, Jamie, do you want to take that since you were at worked in the hospital for quite, Jamie worked for about 10 years at Beth Israel. Yeah. Can you?
So, well, once you're back home, the physical therapist, it can come and do an in-home evaluation. So that would definitely, be an opportunity to get, equipment in place then. While you're still in the hospital though, I don't know, Sharon, do you, like, if you're currently in the hospital?
It's very difficult. If you're currently in a hospital, you're not there to, first of all, give people access, and you're not there to, and also, you may have things that may have changed. So what you might have needed before, you might even need more of. So it's not, it really, as Jamie said, you really need the physical therapist, occupational therapist to come in, do an assessment, and order the equipment, which they can do fairly quickly. But it is true, you're going to come home, and at that point, it may, for example, not be safe for you to bathe. You may need the home health aide to give you a bed bath while it is worked out about what would be the safest thing to do for you or with you. There are a very few community agencies that will come in and do some of these things for free. Jerry Pear, and there are some other ones that, you know, you can try to find through Department of Aging to see if they will help you do some things that are not Medicare covered, because not everything is covered, you know, things that, you know, you want to get, ramps and some things like that. UCP does ramps, some different organizations can do ramps, things like that. But to be honest, we expect that people should not go home on home care, especially alone, if it's not clear that they can manage even for a day or 2 days. Most home care agencies will not accept you if you have, if, for example, people want to go home and they can't get out of bed by themselves. They're not good home care candidates. And unless there's someone that's going to be there and they're a one-person assist, they probably can't go to home care, because no respectable home care would accept that case, because they're putting the person at risk. That becomes a case for rehabilitation, and the hope that you could qualify for rehabilitation, even if it has to unfortunately eventually become permanent in-home, you know, in a facility placement.
And I will just add that, I mean, you absolutely can talk with your therapy team in the hospital about equipment recommendations. And, you know, they may suggest some things, or even order, you know, if you didn't use a walker before, but now really need that support, you know, they would order that necessary equipment. But when it comes to like fitting your home, the therapist in the hospital would probably defer to the community therapist that can actually come in and evaluate your space and really fit you for, you know, safe and appropriate equipment.
Thank you. So just a couple of questions just came in asking for clarification. One question is, what is a social admission? And the other question is, how do you make an appeal to stay in the hospital?
Okay, the appeal you make through Medicare, and the information is provided to you in writing at the hospital. And certainly you can ask anyone there on the care team to make an appeal or assist you with an appeal. It would be an egregious violation of your rights if they did not. And I don't think most responsible hospitals would be against the idea, because it's in their favor. You have to understand, sometimes they ask for, if you ask for an appeal, the hospital doesn't not want to treat you. They're just worried they're not going to get paid if they treat you. If there's an appeal and you are sustained, then they will get paid. It's not like they are dying to get rid of you, but they're trying to say that they have to walk a line as to whether you really need to be in a hospital, which sometimes doesn't really take into account the way that it used to years ago when I talked about social admissions, when that was considered to be a major part of the decision. It isn't so much. People were admitted to hospitals solely for social reasons. And that is not something that hospitals really want to participate in, or nor does the government seem to want to sustain that anymore, even though we could see why maybe it should be. Not sure I understand the other part of the question, though.
The question about a social admission, I think.
Okay, so that's what a social admission is. The social admission used to be, back in the day, if a person was found to be just not functioning, whether it was by Adult Protective Services or a family member. A first line of defense was you would just take them to a hospital, have them evaluated in that hospital, admitted, and then they would look to see whether this was truly a medical situation or was more something that required them to have more supports at home, you know, or something that they needed, which would be some form of home care or Medicaid or mental health treatment, could be hospitalization for a mental health issue, especially with APS, it could be something like that. So that's what they used to just do that much more. And today they don't want to do that. They want to assess a person. They don't find a specific medical condition that requires inpatient care in a hospital. They do not want to admit the person. They will try to triage them. And sometimes they do actually wind up having to admit them because they can't successfully triage them. But most responsible hospitals hopefully at least try.
Thank you very much. So we have a lot of questions coming in. Let's move on to situations where a person might be discharged to a nursing home or skilled nursing facility. And so there was a question about, you know, what patients should be aware of before entering such a facility regarding how payment is handled, who's paying, who to contact about billing information. I think also about one's treatment is certainly important, but then how many days you have to stay, those types of information.
Yeah, they're very difficult questions because the problem is that nursing homes also operate under the reason that they are providing a care that's going to be covered by Medicare. Some facilities are concerned because that's not always easy to figure out. You could come there and just not be able to do anything. You can't participate. If you can't participate in the rehab because you're just too debilitated, or it seems that after 2 or 3 sessions, they realize it isn't making any difference, the facility has a problem in keeping you and billing for that. So this is where things become complicated. You're going there theoretically as a kind of step down thing before you go home. The hope is that they have a very clear rehab protocol in place for you. They evaluate you, they're going to give you X numbers of things or something like that. You know, they'll give you X numbers of days, they're going to, you know, do something else, and that's going to be, you know, something that they're going to try to do. But on the other hand, you may get admitted and then you realize that they're billing you for things and you don't want to be there and you want to go home, but there's no one to assist you and everything. So that's, you know, something that it's a case by case. The people who have the best situation are those who have people to help them. The people who they have an advocate, they have a person, they're connected to somebody. There's a social worker even that they know, if it's not a family member, who can assist them, because you need a little backup in speaking to people and everything. Laura, if you don't mind, I just need a little something.
And then
Okay.
if a person, so let's say a person is in a nursing home or skilled nursing facility, and they're not at a point yet where they're safe to return home, but the nursing home is telling them they're going to be discharged.
Mhm.
What options does a person have at that point?
Okay. I'm so sorry, my little computer issue, so.
No problem.
Okay, so, all right. So the thing about what to do about being discharged and either from the hospital to a rehab or a rehab home are somewhat similar. You would hope that at one point or another, you're doing better if you're leaving the rehab than you were doing if you were leaving the hospital. But, you know, we can't always say. Sometimes, you know, rehab is one of those things that sometimes it can work and sometimes they give it a try and it doesn't work, you know, I mean, nothing against the, you know, but it also doesn't meet the criteria. So again, we want to get ahead of it. When you go into a rehab, the issue is you're there short term. You're not in a nursing home. That is it's a whole different situation. You're not agreeing to stay indefinitely, hopefully, that sometimes that does happen. But that becomes a whole different payment situation. Medicare doesn't pay for ongoing rehab or ongoing nursing home care. Medicaid pays for ongoing. They pay for ongoing care that is really the same as the difference between, you know, having an aide who's going to be a certified aide and is going to do skilled things, and having an aide who's going to go take care of your house. and do things for you, help you with shopping. So, you know, we always need people to start right away talking to the social worker in the rehab. What are your options? If you wanted to stay, if you don't want to stay, and will they set up home care for you? They may need to set up home care for you too. You know, that's really very, very important. If they don't set up home care for you, how are you going to get care? So now you need to engage them and work with them to see if you could do that.
Thank you. So now let's turn to making decisions about picking a home care agency or an aide specifically. There was a question regarding whether you recommend the care.com website for finding an independent care provider. Are you familiar with that website?
Care.com. Recommended. Laura's been assisting me, so she's not quite in her position, but she's going to hopefully answer that. I'm not unfortunately familiar with care.com. I don't know if Jamie is, but so I didn't do as much private pay, to be honest, in New York City.
Yeah, so just in terms of care.com, I think that you know what, it is helpful to explore and use as many resources as possible. I really also encourage word of mouth, you know, checking reviews, kind of looking at those lists, especially of trusted resources like the discharge planner or like some of the organizations that we spoke about. So I think that care.com can be one of the tools or resources that you use, but definitely do your homework and make sure it's you know, reliable, you know, the recommendations you're getting.
No, that's great. And where can you find information about ratings for healthcare agencies, whether that's, you know, whether there are particular websites or other sources?
Yes, absolutely. New York State actually rates they rate home care services, certified home health care services and licensed agencies. And you can go on to the New York State and you can look in the Department of Health for ratings for facilities. They also rate nursing homes as well, rehabs and things like that. But they do rate home care. They give them certain numbers of stars. And this is a thing. The only thing I've been advised to tell people is that these ratings are all based on things that happened about 6 months ago. So there is lag time. And so it's something to think about. But in general, they are helpful because they're an average agency. It goes up to 5 stars. An average agency, you would want at least to be 4 stars, 4.5 stars. If you're dealing with, I mean, it's rare to find an agency. There's actually one that is a 5-star agency. But in general, if you were to look at something and it was 2 or 3 stars, I would say to be thoughtful about, is that where you're looking?
And what about finding reputable private health aides? Are there any particular sources of listings you would recommend?
Well, that depends on whether you have the money to private hire in an agency, a licensed agency. You know, sometimes you get people who are better trained, better supervised, whatever. There are people who obviously have done this work for years, work independently. And so people get references from people that they know. Sometimes you can actually share an aide with somebody. So someone in your building, they have an aide they've had for a time, but they don't need all her hours. You can also, so sometimes people can do that. There is an organization, it's New York Foundation, which is actually one of the city's agencies that is through the Department of Aging that actually runs its own program. They also run a home sharing program. So there are sometimes agencies too that are doing other things that can advise you and give you, you know, some kind of options of picking people. But a lot of it, to be honest, goes to whether you have the money or whether you feel at this point, this is the time that you really need to switch to Medicaid, if you can figure out how to do it. And sometimes this is the investment that people have to make, because some people can do it with the advice of a qualified social worker who knows the system and works with people who put people on these programs. That would have been me. but other people don't know those people. And they find attorneys, or they find geriatric care specialists, or they find people who have this experience. There are social workers around who can do it, but you have to be careful to make sure they really do. The key thing is many of the managed long-term care programs will do it for you themselves. If you engage with them and you're a serious candidate and you want home care, either for yourself or if you want to do it through spousal enrichment that we talked about, and they'll help you. They'll actually help you do the application. They will help you get onto the program. They just can't determine the number of hours anymore, but they will help you. So people should not be shy to call up some of these places. There's a listing of them. The New York State Department of Health has a listing of all the approved ones. You can get their materials, you can talk to them and get that help is one key. Whether you have to also pay somebody depends on your situation.
Yeah, and one question that just came up was about, should I apply for Medicaid now or wait? I very much encourage, there has been they did implement a look back, a 30-month look back, meaning that one would have to show all of their assets from 30 months back. Medicaid currently, community Medicaid at least, one can apply just, with the current assets and put in that paperwork. So that look back is supposed to be implemented in 2025. So if people are considering applying for Medicaid, now would be the time, and pooled trusts are a really good tool to use.
Okay, great, thank you. So there are a lot of questions about, how to cover different costs related, to home care and receiving support. I just want to quickly ask first, if people are having difficulty working with their home health aide, perhaps they're having a hard time communicating because of language barriers, perhaps, the aide is not providing the services that they really need, or to the extent that they need. Are there any suggestions, just brief suggestions, for what someone might do? What would be the best way to handle that kind of situation? I know that can be challenging for folks.
Okay, so I'm sorry, just a little bit of a recap because I was kind of a little focused on
Yes. At a computer.
I can
Unfortunately, you have to put me on.
So the question is essentially, if someone is having a hard time working with their home health aide, there might be language barriers, there might be other issues. What are circumstances where it's warranted maybe to request a change in home health aides?
Yeah.
Or what other suggestions do you have for dealing with that?
Right. So, this comes up all the time. It is not as easy, and bear in mind, especially when it's like very short term, like on Medicare. Sometimes the agencies are just going to say, you know what, we're only giving you 2 weeks of care anyway. So, kind of try to deal with it. And sometimes also with Medicaid, resources are very stretched and it might be difficult, but I highly, highly encourage, and it's important, especially if you're privately paying through an agency, highly encourage talking to that agency, finding out what are their protocols for making changes. And especially if it's a language barrier, or even somebody who's hard of hearing can't understand accents, crucial. And crucial also, if you're not understanding, you want to make sure that it's somebody who, God forbid, in a crisis, is going to be able to communicate to EMS also, right? Or, in some other situation. So I would say it's important to try.
Thank you. So regarding paying for these services, I'd like to ask a general question first. So for folks who, need to ask questions about whether it's, opening a pooled trust, or working with their long-term care policy and, what can be reimbursed, just different questions about, what Medicare or Medicaid will pay for. Are there any organizations that you would recommend, that people could speak to ask these kinds of questions?
Yeah.
I would think with Medicare, the Medicare Rights Center, which I believe is one of our recommended sites, is someplace that really helps you understand what Medicare is supposed to cover. So at least you have an understanding of what it does and it doesn't do. So I think that's always a really good place to start there. Medicaid is difficult because Medicaid itself doesn't really provide a lot of information to people who want to apply. As I said, they don't want to talk about spousal refusal. They don't want to talk about some of these other things. They would like people to just be eligible on the guidelines, apply and get Medicaid. So, you know, you really, the more you have to do in order to become eligible, the higher level of help you're going to need. So people who really have property or a lot of money, whether you personally think they should or shouldn't apply for Medicaid, may need to apply anyway because they just need so much care. And if that's the case, they may need somebody far more experienced. They may need a lawyer. I mean, you know, they may really need a geriatric care specialist. There are other people who, looking at their situation, can just apply for a managed long-term care program, but they're only applying because they need it. This is not usually, you know, when people think, oh, they all have Medicaid, that's so wonderful. It's not really wonderful because the only reason you're doing this is because you can't function anymore independently. So you have to look at that as you know, something that we have to be cognizant of. People need support in getting the care they need to safely stay at home. And actually, the state constitution of New York says that it is in our interest as a state to keep people at home if they can stay at home safely.
Yeah, so, and some other links that we provided for Medicaid questions, Community Service Society has a program called ICAN, ICAN, which is an ombudsman program. So they do have information, you know, and referral phone line that people can call into. In addition, New York Legal Assistance Program can assist and help with advocacy. For those applying to home care, they're excellent and they have really good information on their website. And New York Connect, those are the agencies that were given, you know, contracts through Department for the Aged. You can even access them through 311. So for your borough, they will be able to also give some information about home care in general.
And I also really would like to remind too about ICAN, which is a great organization. They're also very helpful if you are having a problem with the numbers of hours on your home care, that they're trying to reduce hours, or that the New York Medicaid Choice is just not providing appropriate hours. And NILAG, which is a special legal service that has really been working in home care, is really helpful in those areas because sometimes you really need it, but either it hasn't been quite correctly done, you know, so your application has been just for the third time, like tossed out or something, you know, they really help with things like that. They really help get you the attention you need.
What about with long-term care policies though? Because we don't have time to get to all of the questions, but there are questions related to long-term care policies, you know, what they will cover, how to get reimbursement. Any suggestions for a good resource for folks?
The problem with a resource for those, other than, you know, there is a Department of Insurance in the state that would help you. I mean, they have to, I mean, it's a form of insurance. So whichever department does insurance would have to look at it. The problem is that they're all so different. You know, they've been written, many of them are very old. They barely even sell them today because they've cost them a lot of money. Some of them were back in the day excellent. $300 a day, for example, you could get, and for a very long time. You know, today, you know, as I think Laura had said, you get more minimal hours and you get more, it could be, they could say 2 hours, that's a day. So if you stuff your, you know, you only have 60 days or 90 days, or you know, have this or that. But this is where it's very difficult. What you need is somebody, possibly a lawyer or possibly somebody with that kind of level of education who could read through it, toss out what doesn't seem relevant, and figure out exactly what it's saying. How many hours, by whom, for how long? Because those are your key things.
And there actually are people who that's a job that they do. They work as advocates, assisting people with insurance issues and specifically with long-term care policies.
Okay, wonderful. So we are very close to the end of time. I want to try to squeeze in this question. For people who are feeling overwhelmed, and they're, the folks who are listening today may be dealing with a situation, or perhaps they are concerned about, future situations. How can someone get support? So there was a question if more information could be provided about care managers, or, just receiving support with all of these decisions that need to be made.
Yeah, so I mean, geriatric care managers are excellent. It can be a costly type of service. It's not unusual, $200 an hour or something, but sometimes we do encourage people, especially when there's something complicated, to consider them, and or even just to consider like using them just for that initial planning. Or, and to know that, that's possible, or even to know, oh, in the future, if I do like really need someone, I have someone interviewed and I'm aware of, what they provide. But I would, again, I think that all of these, some of the organizations related to certain illnesses can provide support and information. These case management programs through Department for the Aging cover specific neighborhoods and areas, and have case management, and can also provide information. And sometimes I know with our organization, Jamie and I handle the intake calls, and often if we're hearing, it's something that we can't quite do because of geography or something, that we're giving some other ideas as well of where to go. So sometimes it's a matter of doing that exploration on websites, or by making the phone calls to get more of the info about where to go.
Thank you so much. And I just want to acknowledge that we received so many questions, and I know that this can be very stressful for individuals. So I just want to remind all of you that you will be receiving the contact information for Laura and Jamie if you have follow-up questions. I also want you to feel comfortable calling our office. You can speak with me if you have follow-up questions, and I can help direct folks to, the resources that will be helpful. So once again, many thanks to Laura, Sharon, and Jamie. We so appreciate you participating and sharing all of this very valuable information. We have a number of events coming up that we just wanted to quickly share with folks. On July 16th from 10 a.m. to 2 p.m., Senator Krueger is holding an in-office rent-freeze clinic where individuals can get one-on-one assistance with applying for or renewing their SCRI or DRE. The clinic is co-sponsored by the City Department of Finance, and space is limited. You must be a resident of District 28, a rent-regulated tenant, and you must register for the clinic in advance. Please call our office if you have any questions. The link to RSVP is being placed in the chat. Senator Krueger's next Older Adult Roundtable will take place on Tuesday, August 6th from 10 a.m. to 11:30 a.m. and is titled Promoting Your Financial Security, the Power of Investing Stocks, Bonds, and Managing Risk. Thank you all very much for joining us this morning. We hope that all of you enjoy the rest of your day and stay cool.